Hello, my name is Stanley Fleming, and I'm a fourth-year medical student, and also a member of the SIR Reserves. Today we're here at Emory University to take a look in the day in the life of an interventional radiologist with Dr. Park and his team, who's going to be placing a gastric tube. Interventional radiology is answering a lot of questions and providing options to patients who have few others. So come with me and let's take a dive into the day in life of an interventional radiologist with Dr. Park and his team.
Each day starts with a morning huddle, a chance for the team to run the board, discuss the day's cases, confirm logistics, and make sure every patient receives the best care possible. Now we'll meet Dr. Park, who will brief us on how a gastrostomy tube is placed directly through the skin of the abdomen and into the stomach, so that food and medications can be delivered into patients who can no longer swallow normally.
I'm Peter Park, one of the IR attendings here at Emory. We're about to do a gastrostomy tube placement under fluoroscopy imaging guidance. This patient had a recent craniotomy for meningeal resection, being in this altered mental status and not able to have anything by mouth. We're going to do enteric access gastrostomy tube for her so she can get long-term nutritional feeding through the access. The techniques that we'll be using today is a balloon dilation techniques. This has, believe has advantage over the traditional push kind of pillow dilation technique because it's less pain generating, it's more comfortable to patients. There are a lot of advantages to in terms of not losing air insufflation during the case, requirement for less sedation during the case, less bleeding risk. Thankfully for this patient we had cross-sectional imaging available for review, which we reviewed during morning rounds. The CT showed a really good window to the stomach without any intervening overlying colon or liver. But we'll double check again with ultrasound and fluoroscopy just to be sure that this is a safe window. So it should be a good case.
Now, Dr. Park will show us how he uses ultrasound to confirm that the procedure can be performed safely. With the ultrasound, he marks the edges of the liver and rib cage, establishing safe boundaries in which to work.
Before we prep, although we did look at her pre-procedure CT imaging, making sure that there's no liver or bowel loop in front of the stomach, we're going to still mark the liver. So you're going to see the ultrasound. This is your side. We're going to find the liver edge, so the left lobe is right there here, and this is kind of the edge of the liver left lobe. Now as we go down, this will go more toward the right. Now we don't see the liver anymore, so we know this is her liver, so anything left of that is good. And then we palpate her subcostal margin, so we don't want to go above the rib. That's going to be painful due to. So we create a space. We can probably just prep. Here like that. And that'll be more midline G2 for her, but this will be a good site. It's okay. So we've looked at with ultrasound. We'll start prepping.
Once everything is prepared and safety is confirmed, it's time to put on lead, scrub in, and complete the final procedural timeout.
Gastrostomy tube placement under fluoroscopy is a routine procedure that we do every day in IR. It's something that it's a high volume procedure pretty much everywhere where IR service is offered. But gastrostomy tube placement is a high-risk procedure that can go wrong very quickly, requiring surgical emergency, surgical backup, and it's something that we take very seriously and then make sure that we do this right without any risks to the patient. This balloon technique that I described a little bit earlier, traditionally the G-tube kit comes in with this telescoping pillow sheet, but that has potential for, if you're not careful, you can lose all of the injected air in the stomach while you're pulling the pillow sheath out. If that's the case, you basically lose access to the stomach wire can flop out of the lumen. This technique was invented by Dr. Peter Bream, and this is a smart way of using the balloon dilation as our dilator just advance right over the balloon. So you're going to put the gel here, and then I'm going to put some gel over here too. This is an 18 French MIG G-tube. Then you're going to load this non-compliant balloon, 8mm by 4cm balloon right through the tube. So it's coaxially loaded. So the balloon will insufflate to 8 millimeter in diameter, and then this 18 French G-tube will right over it. We have the 3 T-tacks, we'll have the 18 gauge open entry needle, and then we'll have the insufflator ready. Okay, the first part is to assess the window. So we're going to take a quick look at her prep area. So her, we gave barium last night to visualize the bowel. It's still moving along. It's mostly in the small bowel now. Some has reached the right colon here, so it's kind of predicted from CT. This is more like a midline G-tube, right? Okay, we're ready for insufflation now. So insufflation is a critical part of the G-tube placement, right? We want to stretch the stomach as much as we can first to create a window, but the secondary advantage of adequate insufflation is we can decrease risk of bleeding or puncturing through major vessels in the stomach, because as the walls kind of stretch with insufflation, the vessels kind of along the wall also stretch, right? So there's less risk of puncturing through the vessels, namely gastrocolic artery. So as you can see, we're insufflating the stomach. It's getting larger, distended, and then not a lot is passing through the pylorus, right? So this will be a good window. Yeah, we'll assess the window on AP first, and then we'll do some angulations during the act. Doing great, keep going.
Okay.
It's getting distended nicely. We want at least 500 cc of air in the stomach. The more the better, as long as the patients can tolerate insufflation without getting nausea. Sometimes they can get really nauseous if you distend the stomach too quickly, and they'll throw up and it'll become a huge issue on the table. So it's getting really well distended now. We're gonna get a marker. It's getting there. We want to access the stomach at the level of that duodenal C loop, right? At that parallel line, at the level of that, just to have an optimal access. Okay, we're done with the insufflation for now.
Okay.
This is our G-tube site. And we need the 3 T-tacks about a centimeter apart from each other. So we want that to be nice tripod to kind of support this gastropaxy. So ideally we should do our best to deploy 3 T-tacks every time. 2 T-tacks, sometimes people do that, but ideally we want that nice tripod rather than linear line to kind of anchor the stomach wall of the abdominal wall. So now we've identified, we drew markings here. We're going to do a little bit of lidocaine. Okay, we're injecting lido without epi. So we're going to give a little bit of nice skin roll at the access site. So under deep sedation, so it shouldn't be too bad. That's enough. I'm going to go a little bit deeper with the lido. Always aspect the needle back before you put the lido. Make sure that you're not in the vessel. Okay, so now we're done with the locals. Alright, start coming back. Yeah, so we're gonna do a tiny skin nick. T-tack access site. Okay. We're gonna make sure that this is over the stomach on AP first, right? So we're gonna put that over AP. So we're on the stomach, right? Some people do this advancement under lateral. I like to do a little bit on RA oblique to kind of get my hand out of the way. So about like 15-20 degree. You still have to make sure that this T-tack needle goes straight down, perpendicular to the wall. So not at an angle like this. We want this to be a nice and tight anchor. So still 90 degrees straight down, but we are a little bit right oblique, so my hand should be out of the way. So I'm going to keep going until you see the needle kind of going into the stomach. I'm going to aspirate it. Aspirate the air back. Air is out. So I'm going to inject some contrast. Right the stomach. Push this thing in. String off. Put this, test this in the floral. We'll tack that. The kit comes in with a 4 T-tack just in case one gets lost or something doesn't work out. So, but we'll do total 3. So again, over AP, just make sure that you're over the stomach right there. And then we're going to go to RAO 20 again. Alright, so straight down, the same thing. And then my hand is out of the way. Stomach puncture. Air back, syringe, and then inject contrast, the stomach. push this T-fax in, take the spring off, and test under fluoro that it's protecting the wall nicely against the abdominal wall. Sure back, thank you.
Thank you.
We need one more.
First feedback.
So same thing, over the AP side, check it. Alright, over the stomach, I'm going to go over to the RU20. Go ahead. That's good. Alright. Collimate a little bit, side to side. That's good. Thank you. Alright, straight down the stomach, puncture, air back. Good contrast. Alright, the stomach, push it in, the string off. Test this under fluoro. Okay, so have a nice 3 T-fax. So our difficult part of the procedure is now complete. We just have to make large enough hole to introduce our G-tube into the stomach. So I'm gonna make about a centimeter horizontal incision over this entry side. Adequate soft tissue dissection is very important. Make sure that nothing gets hung up on the soft tissues. Be very liberal with the soft tissue dissection. 180 035 stiff ampouts wire ready. So this is open needle, so you don't need inner. We just go directly into
Go back to AP.
the stomach. And I go back to AP again, just making sure this needle is right over the stomach puncture site in between 3 T-tacks. So right now we're in between 3 T-tacks. Alright, here I'm gonna just, you can go back to RAO20. Okay, so it's the same thing, straight down into the stomach, like that. Aspirate air back. Inject contrast. We'll save that one. Put this wire right through. Wire into the stomach, let the wire kind of pull over the wall of the entry. The wire is now working very well. So we're gonna take this needle out over wire, sharp coming back. I'm gonna load it over the wire. Once the balloon is loaded, we'll make sure we'll bring the G-tube all the way up close to the trail edge of the balloon. So what I'm gonna do, we're gonna bring this balloon all the way up to the trail edge of the tube. Push this in. We're gonna go and insufflate. Insufflating. And we're gonna do this under fluoro here. And then Mahmoud, you're gonna go and insufflate the stomach. Insufflating. And we're gonna do this. Push all the way things back, and then we're gonna slowly push this tube over. A bit of store water mixed with a very dilute amount of contrast. I'm gonna insufflate this cup. Very dilute amount of. We're gonna pull this thing over the wire first, up against the stomach. We're gonna keep the wire in until we're certain. We're gonna pull this thing over the wire first, up against the stomach. We're gonna keep the wire in until we're certain that we're in the stomach here. It looks like we're in the stomach, right? But we're gonna G-tags, we're gonna inject some contrast to the G-port. So it looks like we're in between 3 T-tags. We're gonna inject some contrast to the G-port. We'll see. And finally get rid of the wire here. Alright. Get rid of the wire. Nice and easy. Cinch it up. And then we're gonna leave this to the grab for 4 hours. So the things I like to do is the MIG tube has this balloon port which is easily mistaken for a flushing port. So this is what they accidentally inject some contrast or saline and then the balloon bursts. So I crush this so that no one can access this. And then no error can happen. So that's the site. Some oozing which is expected but not actively bleeding. This is good. Go ahead, remove her NG tube. And then we'll put the gravity back 4 hours.
4 hours.
We'll put the orders in for saline challenges.
Okay.
So we'll do the debrief. As you just saw now, the procedure, gastrostomy tube placement, is a routine procedure that we do almost every day because there are a lot of patients needing enteric access. Here in this hospital, we do take care of most of the G-tube placement under fluoro. It's safe, much less invasive than open surgical G-tube. It is something important to do well, like I was mentioning during the case. If something happens during the case, let's say you lose air out of the stomach, you tend to lose the wire access into the stomach pretty quickly after all the air gets deflated. At that point, you cannot really go back into the same hole that you created, which now there's a gastric perforation and becomes a surgical consult. Some of the challenges that we encounter during G-tube, losing air, you can encounter excessive bleeding, which mostly is venous in nature, so we can control that. But if it's very brisk arterial bleeding, that we suspect that something happened to the arteries. So sometimes patient can get really nauseated during the case with a lot of air introduced rapidly, so they can get nauseous, they vomit, and now at that point patients supine on the table, which will put them at risk for aspiration. G-tube placement it's not something that you necessarily have to see the patients in clinic unless it's for special occasion. Usually most of these consults come through us. It's something that's a high impact and it's gonna help a lot of patients long term. So yeah.
Hi, I'm Kasturi. I'm an M4 at Emory, and we're headed to DR Lunch Conference. Come with me.
One of my favorite parts about my time at Emory University is the spontaneous teaching that takes place throughout the day. Any question posed to an attending can spark an impromptu lecture. 3 or 4 times a day, all of the students would gather around a computer for a focused discussion on that very question. To me, this reflects the welcoming and collegial spirit of Emory University. At the end of the rotation, students are expected to present an interesting case that they observed at Emory. Here, Dr. Brandon Lay guided me through some of the more intricate details of one of his cases, which ultimately became my end of rotation presentation. This is just one example of how attendings invest so much in us. They genuinely love to teach and provide individualized attention to each student throughout the rotation. Now let's meet back up with Dr. Park to hear about his journey to interventional radiology and to learn a bit more about Emory's program.
First day I rotated in IR, I kind of knew this was for me. I mean, it's like, you know this is for you, like the moment you enter into the IR suite. At the time, our mentors there who are now my partners here in this practice, I just got so much advice from them, and I got involved with SIR, go to meetings, annual conference, and I just loved it. So I decided to do an IR fellowship, and here I am. Thinking about kind of choosing this awesome field. First of all, this is a highly professionally satisfying career in medicine. I mean, you learn imaging, you know how to interpret the imaging, but you know how to apply this knowledge into a patient's clinical scenario so that you can fix their problems. You have to keep that in mind, although interventional radiology has a radiology name in it. I consider this field to be equivalent to surgical subspecialty. So you have to have a surgeon's mindset, the way you interact with the patients, with the referring physicians, the way that day is set up in terms of workflow, rounding, doing procedures, clinic follow-up. These are some of the things that you have to get acquainted with, and this is very analogous to surgical training. So you have to have a surgeon's mindset. Of course, you have to know how to learn how to read images, and that's very important foundation of IR, but have to be willing to work hard, take calls, get challenging cases, get innovative whenever you encounter a problem. So these are all of things that you would consider. Nowadays, a lot of people will consider surgical internship before going to IR. I think that's really good trend, so that you learn how a surgeon thinks. We're a problem solver, so we have to innovate and apply all these amazing skills to help patients. Here at Emory IR, my kind of focus area is in interventional oncology. I take care of a lot of patients with the liver tumors, liver disease, portal hypertension. I like the fact that I interact with a group of doctors in a kind of longitudinal basis. So I participate in liver tumor board. I talk to them all the time throughout my time here, hepatologists, oncologists, surgeons, transplant team. It makes my job more meaningful, if you will. Like, you're not just working in an isolated setting alone, you're working as a team, so it makes a huge difference to the patients that we take care of together. I like the fact that we operate through outpatient clinics, so meaning that all the patients that will come to us for procedures, we see them initially in clinic. We discuss about the procedures, about the plan, the alternatives, and they come to us. We do the procedure, we send them home or admit them occasionally, and then we see them again in clinic. And it's not like one-time episodic encounter. You see them long-term. For some patients, it's lifelong. And it means a lot to me that I have patients that I can provide care to kind of help with their disease process. And then in that process, you're part of the team. You work with your IR colleagues, you work with other doctors in other specialties. A day in IR is never boring because it's full of ideas, innovations, the discussion. All of this makes my job very satisfying and meaningful. When medical students come to us to rotate with this 4-week elective, they'll be integral part of our team, so meaning that they present patients, they see them, they write progress notes, they come up with their plan, discuss them with attending. So students will be fully integrated into a clinical team here when they are here. Even if it's just for 4 weeks, we maintain a very busy practice. And there are a lot of sick patients that we take care of. So you'll be expected to share your knowledge and learn together. And we're here to support you and get you the idea of what IR is like in real practice. It's a busy academic practice, a lot of high complexity cases, oncology patients, transplant patients, vascular patients, pain patients. There are a lot of different subspecialty areas that we offer here at Emory, so it will be a lot of fun. Emory is a very large healthcare system, so we have multiple hospitals that you can rotate through. One hospital is different from the others. Each hospital is kind of functioning as its own center of excellence. So if you come here at Emory University Hospital, you'll see a lot of liver patients, transplant patients, oncology patients. If you go to the Midtown Winship Center, you will take care of a lot of cancer patients, a lot of pain management. We have Grady, the County Trauma Hospital, we have Children's Hospital. So there are a lot of, it's a full gamut of IR practice. Although 4-week period might be a little bit short to experience all the facets of Emory IR, but I think you're going to enjoy your experience here. Whatever interest that you have, we can tailor to your needs. And then the other unique part of our practice, we're the innovation center. So we work with our Georgia Tech bioengineering department to kind of come up with a new device design or new ideas or how to improve our workflow, this industrial engineering in terms of improving the room turnover time. Like, it's a lot of initiatives that you can pursue with Emory IR between Georgia Tech and us. So if you're interested, we do offer a research fellowship where you'll be part of the longitudinal team looking at all this project that you can pursue with IR faculty here at Emory if you're interested in that. That's some of the unique things about Emory IR that we offer. We really, really love teaching. So you'll notice here that a lot of our attendings are very invested in education of our trainees, not only students, but residents and fellows and such, and our staff, nurse and techs. You'll really enjoy the learning environment here, very welcoming. We look forward to working with you.